second. Let me check. Going live. It's coming that we are going live, and now I am live, everyone. Hello, everyone. Is my voice coming? Everyone, yes. A beautiful class today. Today, the topic of choice is case presentation. Let me know if my voice is coming to everyone. Today is a very important class, actually. We're going to talk about some important stuff regarding cardiology case presentation. It's a brand new class with some amazing stuff, with some amazing, mind-opening questions we have. And yes, I hope my voice is coming to everyone. Is my voice coming? Yes or no? Great. Okay, let's start this beautiful $1,000,000 class. Good evening, everyone. My name is Dr. Anand. I am MD Pediatrics and I have done my MBBS from Bangalore and I have done my MD from TMU UP and I'm assistant professor in a medical college. And this is a beautiful channel of pediatrics by Dr. Anand, and I have a teaching experience of many years, and we teach to all the amazing students of UG, PG, MD, DM and MRCP CH. Let's start this beautiful class. Today's topic of choice will be amazing cardiology case presentation. Now today's topic of choice is different, okay? Like I want you guys to participate because today's class is all about participation. Hello, Dr. Ritu, Faizan, Vaishnavi, Dr. Osama Sheikh, Shubhangi, and our dear Shubham from Vikaspuri, Delhi. I know your address also. And yes, hello Sunbi, hi everyone. Let's start this beautiful class, guys. So yes, before starting any amazing segment, we always have a motivating quote, and today's beautiful motivating quote is, most importantly, remember guys, you are possible. You can do anything in life, okay? Please tell yourself that you were born to rock. Tell yourself that you are amazing, and you know there is nothing known as impossible. There is nothing known as impossible, because if you break the word impossible, it says I am possible. I am possible. So you are the best version of yourself. You are the best man of your life. Just breathe, just enjoy and just be happy. Life is just one, guys. You have no idea. You कहते हैं ना हिंदी में, पता नहीं कल कौन सा गम लंबा टाइम खींच जाए. So आज को मस्त तरीके से enjoy करें. Please enjoy life. Life is the most beautiful gift you can ever present to yourself. Let's start this beautiful class. So yes, today we have a case presentation. And did you like this transition of parda coming and going? It sounds very classy, actually. Yes, exactly. Perfect, Dr. Apurva Mandal. Very good. Yes, now today is a very nice case presentation. I want you guys to participate, okay? Because today it's gonna be some crazy ride, okay? Yeah, the case presentation. Yes, the case presentation let's start this beautiful case presentation. So see, it's like I'm gonna tell the case now. I want you guys, most importantly, that have a copy and a pen, okay? Have a copy and a pen, and it's a proper case presentation. I want you guys seriously put your good vibes, put your mind in the center. Just talk to me. It's literally a proper final year MBBS case presentation. If you really want to pass your internal and external exams, and also if you're planning for third year MD pediatrics, this is the case presentation for cardiology. So pen, pencil ready, brain ready, and typing ready. Okay, so I am a student, okay? I am a student. Let's start this case. Good evening, everyone. I am presenting a case of 11 months old patient named Anand. See, listen very carefully. Whatever highlighters you feel, no, please note down very quickly, okay? Because the story will revolve around this only and that only, age and sex and everything, right? Perfect. Good evening, everyone. I'm presenting a case of 11 months old patient named Anand, fourth by birth order of a non-consanguineous marriage, Hindu by community, residing in New Delhi, which is bought by the mother. The informant is mother. Most importantly, my 11-month-old male patient I have, okay? He came with complaints of fever and cough since 10 days and breathlessness since 7 days. So every one of you, listen very carefully, okay? This is a brand new session, okay? With a total new question, total new answers, okay? So this is how you present a case presentation, okay? In your exams, guys, see, you guys will be MD, final year MBBS, intern, externs. This is how you present a case. Remember that. I'm reading for the last time. Good evening, everyone. I'm presenting a case of 11 months old patient, male patient named Anand, fourth by birth order, born of a non-consanguineous marriage, Hindu by community, residing in Delhi, bought by the mother, and informant is the mother, came with complaints of a fever and cough since 10 days and breathlessness since 7 days. My first question, what is the rough differential diagnosis comes to my mind if a patient has come with fever and cough since 10 days and breathlessness in 7 days? Can you tell me a very beautiful answer? Any differential, bro? If at this point, if you're just standing and you and me both are doctors, okay, so Dr. Shubham, what do you think? We have a patient who says fever and cough since 10 days and breathlessness since 7 days. Any one differential diagnosis? Please put an answer in the comment section. You are the best doctor, right? You are the amazing doctor, so please tell me your amazingness. Okay, exactly. Dr. Vaibhav has a very beautiful answer. Yes, Dr. Vaibhav says, can I say this could be a case of pneumonia? Yes or no? Very basic, no? The pneumonia, have you heard of pneumonia? Exactly. If I stand at this place right now, fever and cough since 10 days and breathlessness since 7 days, I think this looks like a case of pneumonia. Okay, and I have a one very important PG question right away. What is pneumonia? What is severe pneumonia? And what is very severe pneumonia? Can you please answer in the comment section, please? What is pneumonia? What is severe pneumonia? What is very severe pneumonia? You have 5 seconds to answer this question. We have done this before. Anyone? Yes, beautiful, answered by beautiful people. The beautiful answer for this question is number one, there is nothing known as very severe pneumonia. According to the new ARI classification, acute respiratory illness classification, there is nothing known as very severe pneumonia. It is only pneumonia and severe pneumonia. Fast breathing plus minus chest indrawing, very very important FMG question. 2 days back only I took a class in Delhi, and there only I taught pneumonia and severe pneumonia. Fast breathing plus or minus chest indrawing. Fast breathing plus or minus chest indrawing is known as, very importantly, pneumonia. And if the patient has danger signs, that is known as severe pneumonia, right? Perfect. Dr. Osama, very good, Dr. Osama. Mera pyara bhai. Yes, so fast breathing plus minus chest indrawing is pneumonia, and if there is a danger signs, it's known as severe pneumonia, and there is nothing known as very severe pneumonia. Let's move further. Okay, so now if I go to, listen very carefully, I hope you guys are having a pen. I hope you have written it. Fever and cough 10 days, breathlessness 7 days, 11-month-old patient, finished. That's the main highlighter. Coming further to the history of presenting illness, patient was apparently normal 10 days back when he developed fever, which was moderate to high grade, not associated with chills and rigors, relieves on medication, and it is present throughout the day, and there is no diurnal variation in the fever, number one. And also the patient was active in the interfebrile period. This is what I have explained HOPI regarding the fever. It was moderate to high grade, not associated with chills and rigors, relieves on medication, present throughout the day, no diurnal variation, and active in interfebrile period. Okay, quickly, Mariam says, can it be bronchiolitis? Yes, Mariam, it can be bronchiolitis, but usually we say that bronchiolitis is a happy child. It's a happy child. Normally, the bronchiolitis, yes, the patient will come to you with fast breathing, and he'll be like a wheezer. He'll be having wheezing. He'll be a happy wheezer. He'll be a happy child, feeding well, but having fast breathing like that. Okay, so this is HOPI of the fever. Coming back to the further points, fever has progressively increased over the 10 days. Doctor, the patient, my 11-month-old Anand is having fever which has progressively increased over the 10 days. Second complaint, the patient was having cough. In the history of presenting illness, the cough was non-productive. The cough was not associated with post-tussive vomiting, and it was present intermittently, basically. I hope you guys are really writing what I'm telling you. I hope you guys are writing. It's like imagine, okay, you are a police investigator, okay? Whenever I read a case now, I'm like a police investigator. Okay, cough, okay, breathlessness, okay, fever, okay, like that, you know? So be that thoughtful. That's it. The cough was non-productive, not associated with post-tussive vomiting, and present intermittently, and there is no postural or diurnal variation in the cough. And the third complaint which the patient had was breathlessness, which I told you last 7 days. So about the breathlessness, it was gradual in onset. Most importantly, it is progressive in nature. It is from last 7 days. This is all I can tell you about the breathlessness. Okay, it was from the last 7 days. Now coming to little more positive history. I hope you guys little idea about it. Exactly, perfect. So coming to the positive history. In the positive, now listen very carefully. This patient he's having fever and cough and breathlessness. There's a history of suck, rest, suck cycle. there's a history of suck, rest, suck cycle. Very important. The mother gives a history, the child sucked the nipple, but he get breathless. Then he takes the rest. After taking rest, again he suck the breast, and again his breathlessness followed by sweating, and again he's taking a rest, known as suck rest cycle. Number one, this is the first highlighter. There is all one second. There is also a history of sweating over the forehead while feeding. There is history of sweating over the forehead while feeding. Mother also gives history of bluish discoloration of lips and fingers since birth. Now these are the three important highlighters. A patient, a 11-month-old child who came with fever, cough, breathlessness. He is also having a suck cycle. He is having sweating over the forehead. That's a very important point. Sweating over the forehead while feeding. Mother also gives history of bluish discoloration of lips and fingers since birth. Since birth. That's important. Okay. Now my question number one is, mother gives a history of bluish discoloration of the lips and fingers since birth. Now tell me what comes to your mind. Can you please tell me quickly various differential diagnosis of a patient coming to you where the mother gives a history, an 11th-month-old child having a bluish discoloration of lips and fingers since birth? Any random guesses? Anyone having cyanosis at birth? What comes to your mind? Very beautiful. Okay, I agree with you. Dr. Shubham says the patient can have a congenital heart disease. I agree with you. Yes, the patient can have a cyanotic congenital heart disease. I agree with you. What comes to my mind is congenital heart disease. That's very well put. Okay. But now my question is, every cyanosis at birth is a congenital heart? Yes or no? Okay, the mother gives a history that, doctor, my baby was having bluish discoloration of lips and fingers at birth. Okay, since birth ko kaat ke, if I write at birth, the mother noticed that thing. Of course, it could be a congenital heart. But now my question is, every cyanosis which is present at birth, is it a congenital heart? Yes or no? What do you think? Can you please tell me any causes of bluish discoloration of lips and fingers at birth? Not since birth, at birth. Anyone? Yes, exactly. So yeah, very well put. Every cyanosis at birth, is it a congenital heart? I don't think so, bro. Every cyanosis is not a congenital heart. Now let's go system wise. Could you please tell me, yes, very important, could you please tell me what are the causes of bluish discoloration? What are the causes of bluish discoloration of lips and fingers at birth? At birth, not since birth, at birth. A 1-day-old baby came with complaints of bluish discoloration of lips or palms or soles. Quick answers, please, quick answers. Such a beautiful answer, such an amazing answer, I would say, by Dr. Wafa. See, whatever you see, you guys are amazing. Okay, we both are doctors, so let's just talk about it, bro. Dr. Wafa says hypothermia. Hypothermia. Is this line true or is this line false? Can a patient of hypothermia can present you bluish discoloration of peripheries at birth? Yes or no? Very quick answer, please. A patient of bluish discoloration of the peripheries at birth, can it be hypothermia? Yes or no? The biggest answer on this planet is yes, 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 yes. A baby who is normally hypothermic, he will definitely have something known as acrocyanosis. Have you heard this term, acrocyanosis? मतलब क्या होता है यार इसका? What is the meaning of acrocyanosis? Dr. Priya Gupta, very good. Acro means periphery and cyanosis means bluish discoloration. So the differential diagnosis of baby having what you called cyanosis at birth, okay, at birth, number one, definitely it could be hypothermia. One differential was congenital, cyanotic congenital heart disease, number one. Number two is hypothermia, that's true. Number three, any other cause? Can anyone please tell me, Dr. Wafa, any other cause? एक baby has cyanosis लग रहा है उसको. The differential diagnosis is congenital cyanotic heart, hypothermia. Any other differential diagnosis? Yes or no? Yeah, बस दो ही हैं. Or do we have only two differential diagnoses or do we have anything else also? Anyone? Quick answers, please. Quick answers. Yes, exactly. So can I go system wise? In the respiratory, can you please tell me respiratory system causes of cyanosis? Quick answer, please. Dr. Apurva, Dr. Chotala, Dr. Anuprita, Mariam, Shubham, Osama, Mukesh, Wafa, Apurva. Yes, exactly. the respiratory system cause of cyanosis, can I write something known as hyaline membrane disease? Yes or no? Do you see cyanosis in a case of hyaline membrane disease? Yes or no? Yes, sir. Yes. If the patient is a preterm, that preterm baby definitely have some problem of surfactant deficiency. Obviously, surfactant, basically it is present in the alveoli of the lungs, which keeps the alveoli patent. I hope you're getting it what I'm trying to tell you, bro. So yes, very important, the respiratory causes of cyanosis, number one is hyaline membrane disease. But for that hyaline membrane disease, of course the baby should be a preterm, then only he will have a surfactant deficiency, and then only the alveoli will be collapsed. Are you understanding now? Now open your brains, okay? Open your brains. Like the take home message is, every cyanosis at birth is not a congenital heart. This is very important, okay? Just because this is a cardiology class, that does not mean that every cyanosis will go to congenital heart only. We will rule out all the other non-cardiac causes of cyanosis, and then we will jump to the rest, to the cardiac causes. That's how the examiner does, you know that, right? That's how the examiner does. In my third year MD pediatrics, I had the same case. A baby having, mother says bluish discoloration of palms and soles and little bit of lips. Examiner, the external examiner, he took half an hour. He did not even touch even a single question of cardiology. He's like, I know you have crammed the whole cardiology line by line, but I am not interested because I know you have read and come. Tell me the respiratory causes. Tell me the GIT causes. Tell me the renal causes. Tell me the CNS causes of cyanosis, but I am not interested in the cardiac causes of cyanosis. Are you understanding? Yes or no? Yes. The respiratory causes of cyanosis are hyaline membrane disease, very importantly. And hyaline membrane disease is common in preterms or terms. Everyone knows about it, that hyaline membrane disease, it is seen in the preterm babies. Can we have any other RS cause of cyanosis? एक और बता दो कोई. Very beautiful one person has told choanal atresia. Do you agree, guys? Yes or no? This is a very beautiful case presentation where we are conducting, like we are having the topic from a 360-degree angle. Okay, choanal atresia. Any special things of choanal atresia? I am a FMG student. I have no idea what is choanal atresia. So see, this is a beautiful picture. If you know this one, this is my mouth and nose. So easy to pass a orogastric tube, but very importantly, failure to pass a nasogastric tube because there is a nasal blockage. Choanal means nose, atresia means abnormal narrowing, right? Failure to pass a nasogastric tube, and yes, that the patient definitely can have cyanosis, right? So the differential diagnosis of cyanosis are very importantly बहुत सारे हो गए हैं. Number one, hyaline membrane disease. Then we have choanal atresia. Have you heard of transient tachypnea of newborn? Can you please tell me a very quick answer? Transient tachypnea of newborn, is it common in preterms, terms, or post-term baby? Anyone? Anyone? Exactly. Yes. Very good. See, so beautifully we have Dilpreet Kaur, Anuprita, we have Priya, Naved, Apurva, Suman, and Indian lovers, and Osama Sheikh. Yes, the brother. Yes. Pulmonary alveolar proteinosis. Yes, that's definitely can cause. So transient tachypnea of newborn is the most commonest cause of distress in a term child. 3 PG question. Can you please finish? In the preterm baby, which condition can cause cyanosis and distress in a baby? Hyaline membrane disease. In a term baby, which disease can cause cyanosis and distress in the baby? Transient tachypnea of newborn. And last question, which disease in a post-term baby can cause cyanosis and distress in a baby? I think the most beautiful answer is meconium aspiration syndrome. Meconium aspiration syndrome. I hope you're getting it. Yes or no? Has everyone understood? Please put a like button. Has everyone understood what I'm telling you? Anyone समझ में आ रहा है? Half an hour, 40 minutes, like ऐसे पानी की तरह जाते, पानी की तरह, literally. Yes, perfect answer. I hope you have got very beautiful points. Okay, let's move further. Let's have a quick revision. What did we do? I said the patient was, I started with the question on bluish discoloration of lips and fingers since birth. If since birth is the answer, yes, I think I'm dealing with a congenital heart disease. And if I talk about very importantly, at birth, most importantly, then other than apart from the congenital cyanotic heart, the patient can have hypothermia very importantly, and then the patient can have hyaline membrane disease. The patient can have very importantly transient tachypnea of newborn, and then the patient can have meconium aspiration syndrome. This is the respiratory causes are over. Now coming to the very importantly, yes, what are the serious causes of cyanosis? Anyone now come to serious causes? Quick answers please. Exactly. 11-month-old baby having cyanosis. Okay, my question was, if the cyanosis is present at birth, not since birth, at birth, what are the serious causes of cyanosis? Can we have the best answer please? Oh, Dr. Amritsus has a very beautiful answer. Other than serious causes, he is saying very importantly, congenital diaphragmatic hernia. Do you agree with this line, congenital diaphragmatic hernia? Very, very beautiful answer, mind-blowing answer. Congenital means by birth. This is the diaphragm which is supplied by the phrenic nerve, and hernia, the whole intestine has gone up, right? So yes, the patient of congenital diaphragmatic hernia can definitely come to you with distress. The best answer for serious causes, of course, of cyanosis is cyanotic congenital heart disease. That's very, very important. And cyanotic congenital heart, we will come to the cyanotic congenital heart. Next question I have is, what are the GIT cause of cyanosis? Very beautiful question, guys. Can you please answer in the comment section, please? Yes, Dr. Wafa, very good. Manish Yadav, mera pyara Manish Yadav, very good, bro. So yes, quick answers, please. What are the GIT causes of cyanosis? Imagine I am the external examiner, you are the student. 11-month-old baby came with cyanosis. Okay, don't forget your case presentation. 11-month-old baby having some cyanotic problem, right? But at birth, if this baby has some GIT problem, what will you answer? I would like to answer, can I answer NEC? Yes or no, guys? Have you heard of necrotizing enterocolitis? Yes, very beautiful. So GIT, tracheoesophageal fistula is more of the RS, na, the upper airway. Definitely upper airway TEF can have a very beautiful answer. Kisne diya itna pyara answer? Yes, very beautiful, Dr. Mariam. Yes, so GIT, gastrointestinal tract causes of cyanosis is nothing but necrotizing enterocolitis. A patient of NEC, the baby who is a premature, the baby who is not on breastfeeding, the baby who is on bottle feeding, having some GIT problem, and then the baby will have an abdominal distension, distress, and cyanosis. So please, guys, can we finish this the causes of cyanosis system wise, bro? What are the respiratory causes of cyanosis? HMD, TTN, and MAS. Very importantly, the cardiac causes of cyanosis, any cyanotic congenital heart disease, which will gonna come now, and GIT, abdominal causes of cyanosis. Have you heard of necrotizing enterocolitis? And very important, in the upper airway, you told me congenital diaphragmatic hernia and tracheoesophageal fistula, and also you told me hypothermia. These all are the amazing causes of cyanosis in a newborn at birth. Has everyone understood this much? Yes or no? समझ में आया इतना या नहीं आया? Please put a like button, or you can give a like thumbs up to right now just on the comment, so that I can understand that you have got it very beautifully. And there are some crazy questions coming in the above slides. Quickly tell me and we'll move further. So please, whenever you read a topic, whenever we have a case, now very oftenly we're gonna have a case presentation for RS, CVS, GIT, puri kitab aane wali samne, and look at the topic from 360-degree angle. Okay, you should be so best, that no one can touch you, no one can even question you. Okay, baby having cyanosis, RS causes, preterm hoega to I think HMD, post term it is there I think MAS, term baby having cyanosis, I think this baby looks like a case of transient tachypnea of newborn. Okay, very good, Dr. Shubham, I hope you're liking it, my dear brother. Great. Acha, ab aage aa jao. Any other causes of cyanosis? And one important cause we covered, right? Acrocyanosis, just now we told, right? Acro means periphery and cyanosis means bluish discoloration. When the baby comes out, when the baby comes from the fetal circulation to the neonatal circulation, normally you can see acrocyanosis in the baby? And can I please finish one PG entrance question in the Apgar score? Do you remember Apgar score? Do you remember 0, 1 and 2 score we give to the Apgar score? Acrocyanosis comes under which score of the Apgar score? Can you please answer in the comment section? Is it 0? Is it 1? Is it 2? Apgar score, like acrocyanosis, very importantly, yes, acrocyanosis comes under which category of the Apgar score? Yes, Dr. Suman has a very beautiful answer. So, question number 1, acrocyanosis, the answer is it comes under score 1. It comes under score 1. It comes under score 1. That is one beautiful thing. Dr. Shubham says 2. बेटा तेरे को जान से मार दूंगा 2. तू मेरा भाई होके 2 बोल रहा है. 2 में क्या होगा bro? The baby will be pink. The baby will be fully pink. Dr. Shubham, please remember, my dear brother, if the Apgar score is a 0, the peripheries are blue and the center trunk also, the part is blue. The baby is totally blue. In a case of acrocyanosis, I would like to give Apgar 1. Acro means periphery. So in Apgar 1, the palms and the soles will be blue, but the trunk will be pink. Whereas in the score 2, the baby is a healthy baby. The peripheries are also pink and the center part is also pink. Remember that, okay? Very good boy. अच्छा इसमें एक question किसी ने send एक पूछा था. Yes, Dr. Suman says what will be the SpO2 level of a preterm at 2 minutes after birth? A very beautiful question. Dr. Suman has a question at 2 minutes of life. At 2 minutes of life, can anyone answer in the comment section? At 2 minutes of life, what is the normal SpO2 of a newborn? Anyone? I forgot. Can you please tell me? I have to clear this exam. Yes, the first minute of life, the SpO2 of a newborn is 60 to 65%. At second minute of life, it is usually 65 to 70%. And third minute of life, it is 70 to 75%. 5 you have to increase, it's very easy. At fourth minute of life, it is 75 to 80%. At 5 minute of life, it is 80 to 85%. And by 10th minute of life, it is 85 to 95%. Very important. I hope you guys know that. Okay, perfect. And one more question, I have it here. Let me finish it off. What is the target SpO2? Can you please tell me what is the target SpO2 of a newborn? If I say preterm or term, मोटा सबका same होता है, okay? Almost the preterms and terms as target SpO2 is almost the same, okay? I don't want you to take stress and very importantly, yes, exactly. So yeah, that's what Suman is asking. Can that SpO2 level is different for terms and preterms? See, Dr. Suman, roughly you remember, okay, 92 max to max 94%. 92 to 94% is the target SpO2 we take, okay? If you want to be very precise, then a preterm baby target SpO2 we keep it till 92, and a term baby we keep it till 94, our target SpO2. But I don't want you to take too much of stress in this point. The basic dictum which you should remember is don't go more than 94%. Target SpO2 of a newborn at 10th minute or 1 day, 2 day, 3 days old baby, don't go more than 94%, because it can cause oxygen toxicity. And the baby can land up into ROP. That's nothing but retinopathy of prematurity. Perfect. Next question, please. Now let's move for the harm. So the final approach of a cyanosed newborn. Number 1, I would like to see whether the cyanosis is central or peripheral. Central cyanosis are we talking about, or peripheral cyanosis are we talking about? Means are we talking about a congenital heart problem, or are we talking about a respiratory or other problem? Number 1. Number 2, whether the child is a sick baby or a non-sick baby. Let's move further. I have more questions to ask you. Yes, now this is a smart question. This is a new question today in our cardiology class. Can we do any test to rule out respiratory versus severe cause of cyanosis? A patient having cyanosis, or also I would say distress, is this sign? Think very beautifully. Is this cyanosis is because of respiratory pathology, or is this cyanosis is because of cardiac pathology? Do we have a test, guys? Can anyone answer in the comment section? I'll be very happy if you can answer this. Anyone? Yes, Dr. Vaibhav Sharma says very beautifully, the answer of that is hyperoxia test. Exactly, Dr. Vaibhav says oxygen supplementation, which is nothing but hyperoxia test. Listen very carefully, okay? Like in a basic like simple words, if I talk about, in a hyperoxia test I will give you oxygen, okay? In the hyperoxia test I will give you oxygen. If your saturation is increasing nicely, you have a respiratory pathology. Even after giving you oxygen, your saturation and your cyanosis is not relieving, then you have a cardiac pathology. Are you understanding? So I'll tell you a little more detail about it. In hyperoxia test, we do the ABG. In the hyperoxia test, we do the ABG. First you do a arterial blood gas analysis. Okay, you get to know the partial pressure of the oxygen and all the other parameters. Main is partial pressure of the oxygen. Oxygen is really important. Okay, you do a ABG. Then you give 100% oxygen to the child. Listen very carefully, okay? This is a new question. My question is, how do you rule out that the patient having this cyanosis, is it because of respiratory problem or a cardiac problem? I'll do a hyperoxia test. Number one, I'll take the ABG, arterial blood gas of the baby, and in that one I would like to see the partial pressure of oxygen. Then after taking ABG, I will give 100% oxygen to the child, and then of course I will repeat the ABG. Are you understanding? Such a simple thing. Give oxygen. If the patient partial pressure of oxygen is improving, means the problem was respiratory. If still the patient cyanosis persisting, still the baby problem persisting, obviously respiratory is not the problem. The problem is the cardiology. The problem is the cardiology part. So that's what. So very importantly, you do the ABG. Give 100. After that, you give 100% oxygen to the child. Then repeat the ABG, and what is the value you will get? That's now. This line is very important. Listen very carefully, okay? This is a very beautiful class. If repeating ABG showing oxygen saturation of more than 150. Now this is what you have to remember, okay? If the partial pressure of oxygen is more than 150, then what is the cause of distress? The cause of the distress was lungs pathology, the respiratory pathology, and even after giving oxygen, my partial pressure is not improving to the optimal mark, then I think I am having cardiac pathology. This is known as hyperoxia test, and very importantly, this more than 150 and less than 150 is what that line we must remember. Exactly. Yeah, that's perfect. We have Dr. Hayat Afghan who says, sir, if you make one lecture about vomiting and diarrhea in neonates, respect from Afghanistan. Yes, my dear, definitely I'll make the lecture on that. It's very easy. I have already made it also. So just be in touch and we will soon gonna have it. Has everyone understood, my dear? This is important, okay? Hyperoxia test. Let's move further. Now, very important. Yeah, now this is good. Now this is a smart question. And this is a very smart question. In the hyperoxia test, I have a question to you now. Okay, now tell me which limb I should do the ABG. Right radial artery, left radial artery, right femoral artery, left femoral artery. What do you think? Which limb, which part of the artery will give me a very good, I would say genuine ABG, the genuine partial pressure of oxygen? Can anyone answer in the comment section, please? Yes, Dr. Panchal has a very beautiful answer. This was the NEET question also. Very importantly, we always should take a pre-ductal saturation. We must take a pre-ductal saturation. We have done this question before. Dr. Amarnath, remember the option is A. We always should take the pre-ductal saturation, number one, because that will give the real oxygen level in my body. Because post-ductal, there will be mixing of the blood and I will not get the real partial pressure of oxygen. Let's move further. Yes, so that's the answer, option number A. Let's move further now. Yes. Now I have a straight back-to-back questions. Now, if a patient has cyanosis on day 1, what do you think, and which congenital heart? Cyanosis on day 1 of life. Perfect answer, clear-cut answer. Can anyone please answer me in the comment section? Very quick, please. Yes. Very good. We have 5 more seconds to answer this question. Very good. बिन तेरे कोई खलिश है हवाओं में बिन तेरे Yes, the most common congenital heart at day 1 of life, undoubtedly it is a TGA, very important. And little more smartly, if I talk about TGA, you know it is transposition of great arteries. And also, yes, now do we have any other condition? Now this is something I want you guys to answer. See, this Oscar ko bhi pata hai. Oscar also knows the most common cyanotic congenital heart at day 1 of life is TGA. Everyone knows about it. Do we have any other more condition where you can get cyanosis? Yes, Dr. Osama, Dr. Shubham, my dear, thank you bro, thank you Shubham. Yes, so the most important is yes. Yes, अभी करता हूँ अमृत, अभी करता हूँ very beautifully. So single ventricle with pulmonary stenosis, single ventricle with pulmonary stenosis, do you agree with this, yes or no? If I wait 1 second, yeah, 1 second here, yeah, single ventricle with pulmonary stenosis, as everyone knows, basically we have a 4-chambered heart. This is the pulmonary artery. Imagine if a patient has only single ventricle, the patient has only single, this is only one ventricle the patient have, and pulmonary stenosis. Whenever there is a pulmonary stenosis, naturally the blood are the lungs are not available for the oxygenation, and the typical best answer is single ventricle with pulmonary stenosis and TGA are the two common congenital hearts with basically very important at day 1. Now see, someone is answering. Now listen very carefully. Now I want you guys to be amazing. Okay, tetralogy of fallow patient, listen very carefully. Tetralogy of fallow patient, I agree, it is a cyanotic congenital heart, but it can never present at day 1 of life. Very carefully remember, okay? The cyanotic congenital heart at day 1 of life, TOF can never be the answer. Why? Why, sir? In TOF there is pulmonary stenosis, and that means a cyanotic congenital heart. So remember, bro, listen very carefully, okay? Open your brains. I'm going to tell you something amazing. In a case of tetralogy of Fallot, if the patient has TOF physiology from the birth, the patient will have a progressive pulmonary stenosis. Progressive, this word is important, okay? The patient, like I'm telling you a little more in depth, okay? The patient will have a progressive pulmonary stenosis, and also there is a part of the pulmonary wall known as infundibulum. Okay, infundibulum. So I would say the patient of TOF at birth, usually that pulmonary stenosis which we are discussing, which we know that the patient have progressive infundibular stenosis. Listen very carefully. Why a TOF patient can never have a cyanotic, like tetralogy of Fallot can never be a cyanotic congenital heart at day 1, because the patient is having a progressive pulmonary stenosis, or the part of the pulmonary valve, there's a part known as infundibulum. To be more precise, the patient will have a progressive pulmonary stenosis. So at birth, you will not see, kind of total stenosis and total cyanosis. It will take some time. Are you understanding, bro? It will take some weeks for the patient to develop a proper, right ventricle outflow tract obstruction or a pulmonary stenosis. That's why the tetralogy of Fallot patient comes to you or presents to you in later period of life. Oscar, class chal rahi meri. Achha, class. Has everyone understood? Yes or no? Please put a like button, bro. Did you understand this much? Can we please move further to the next slide? Anyone? Yes, very good. Please put a like button. 45 minutes are already over in this class. So I mean, अभी लगता है बात शुरू ही हुई है और 45 मिनट खत्म हो चुके हैं. So yes guys, did you understand? Yes or no? Please put an answer in the comment section. Yes or yes. मेरा दरवाजा बंद करना है एक बार. Thank you. ठीक, हाँ, ऑस्कर, वो घर में कोई आ गया एक्चुअली, इसलिए ऑस्कर आवाज कर रहा है. ओके, यस, दैट्स राइट. सो कैन वी मूव फर्दर प्लीज? यस और नो? इज एवरीवन अंडरस्टैंडिंग माय डियर? पुट अ लाइक बटन. थैंक यू सो मच. यस, ओके, यस, ओके. अब बंद कर दो छोड़ के. थैंक यू. ओके, perfect. Okay, let's move further. I assume this much we are beautifully getting it. Let's just move further, guys. Okay, so that's what. So remember now, please update in your notes cyanosis on day 1 of life. Of course it is a TGA, but the other options are single ventricle with pulmonary stenosis and double ventricular with pulmonary stenosis. Single ventricular with pulmonary stenosis and double ventricular with pulmonary stenosis. Okay, now very important. Yes, exactly. Yeah. Yes, Dr. Suman, you are very right, Dr. Subham. ठीक है. अच्छा, one more thing think I have a question. I have a doubt. I have a doubt actually. I don't have a question. I have a doubt. My doubt is, bro, that this if I talk about think, okay, cardiology is like maths, okay, 2 plus 2 has to be 4. Think and tell me single ventricle with pulmonary stenosis or even a double ventricle like a right ventricle and left ventricle with pulmonary stenosis. These two condition, are they duct dependent or they are duct independent? I have a very smart question to ask. Please can you answer in the comment section. My question is the last two diseases, single, if someone having a single ventricle and pulmonary stenosis and double ventricle and a pulmonary stenosis, these two congenital defects, are they duct dependent, are they duct independent? And if you're a newcomer, I must tell you, duct dependent means what I am like asking which duct am I talking about. Can anyone tell me in the comment section? I am asking regarding the patent ductus arteriosus. I am asking regarding the PDA. Are you understanding? Exactly. Dr. Amrit Subro, Dr. Amrit, ये duct dependent होंगे ना? The best answer is duct dependent. See, naturally, any condition, bro, any condition, if I do a pulmonary stenosis, listen very, Dr. Amrit, I need to talk to you. If the patient has a pulmonary stenosis, bro, then tell me the blood will not be able to go right from the right ventricle. When the blood goes to the pulmonary artery, from the pulmonary artery, it should go to the lungs, right? And if there is a pulmonary stenosis, where the blood will go? In that case, I would like to have an open PDA. I would like to have an open PDA so that the blood can go from the right to left. Are you understanding? Dr. Amrit, did you understand, bro? That's why very important. है ना Amrit, समझ गया तू? So that's what. Single ventricle with pulmonary stenosis, double ventricle with pulmonary stenosis, and TGA, they all three are cyanotic congenital heart at day 1. And of course, the PG question, if I talk about TGA, is the first most common. We all know that. Okay, now that's what. So that's what my question is. TGA, single ventricle with pulmonary stenosis, double ventricle with pulmonary stenosis. This comes under which group? The answer was that only, that they come under duct dependent congenital lesions. They come under duct dependent congenital lesions. Yes, Dr. Priya, you are very right, but at the birth it is a left to right shunt. No, see, yeah, exactly, it is a left to right shunt, but imagine, see, Priya, listen to me. For example, if I see, I have a question, very easy question. Priya, tell me very fast. Question number 1, simple question. Okay, tell me, if I just make a 4-chambered heart, and if I ask you, Dr. Priya, that if I ask you this VSD, ventricular septal defect, can anyone please tell me, if I ask you this question specifically, ventricular septal defect, is this a right to left shunt or a left to right shunt? Can you please answer? Very quick answers, please. क्या है ये? Is it a right to left shunt or a left to right shunt? Simple question, simple answer. Can you please tell me, please? Yes, exactly. Okay, the best answer for this question, of course, it is nothing but it is a left to right shunt, right? हम सब जानते हैं. I hope you guys know that it is a left to right shunt because the left side of the heart has a higher pressure, so naturally looks like a left to right shunt. Question number 2, Dr. Priya, I have a question number 2. In a case of tetralogy of Fallot, you know, right, tetralogy of Fallot, where basically you all know that we have the right ventricular hypertrophy. है, होता है कि नहीं होता? There is no right ventricular hypertrophy, and what else we have? There is a pulmonary stenosis. होता है कि नहीं होता? It is there, right? The patient will have a right ventricular hypertrophy. The patient will have a pulmonary stenosis. Or what else the patient has? Ventricular septal defect. It is there or not there? It is definitely there, sir. Ventricular septal defect. Now my question is VSD in a case of tetralogy of Fallot, is this a left to right shunt or a right to left shunt? Can anyone please answer in the comment section? Yes, Dr. Priya, I hope you have understood. In a case of tetralogy of Fallot, that in a case of tetralogy of Fallot, a VSD can never be a left to right shunt. I agree the left side of the heart has a higher pressure and all that, but Baba, this rasta is closed. No, this path is totally closed. if the if the shunt has to be left to right, where the blood is going, normally blood should go to the pulmonary artery, right? There is already a pulmonary stenosis, so the flow of the VSD in a case of tetralogy of Fallot can never be left to right. It is right to left. It is right to left. So the moral of the story is I agree all the VSDs are left to right shunts, but dear, naturally whenever there is a pulmonary stenosis, then naturally, are you understanding, it becomes a right to left shunt. And same happens if I talk about PDA also. If I make a PDA channel over here, everyone knows patent ductus arteriosus is a left to right shunt. But Dr. Priya, if there is a VSD and a pulmonary stenosis, listen very carefully, if there is a PDA, if there is a patent ductus arteriosus with pulmonary stenosis, now tell me what will be the flow of the shunt? Will it be a left to right or a right to left? So obviously, when there is a pulmonary stenosis, patent ductus arteriosus will not be left to right. It will be a right to left shunt. Has everyone understood this much? Are you understanding, guys? So normally ASD, so moral of the story, my dear, ASD, VSD, PDA, all are left to right shunts. All we know that the left side of the heart has a higher pressure. But if I say ASD with the pulmonary stenosis, VSD with the PS, PDA with the PS, then PDA with the PS, patent ductus arteriosus with pulmonary stenosis, then of course PDA becomes a right to left. Has everyone understood? Yes or no? Exactly. Samajh mein aaya? Let me know. Mariam says super. Yes, okay. So the two bin tere is what? Bin tere, bin tere, bin tere, koi khalish hai हवाओं में बिन तेरे. The other bin tere is बिन तेरे, बिन तेरे, बिन तेरे, कोई खलिश है हवाओं में बिन तेरे. So one is बिन तेरे, बिन तेरे, बिन तेरे, and one is बिन तेरे, बिन तेरे, बिन तेरे, कोई खलिश है हवाओं में बिन तेरे. सिंगिंग कंपटीशन नहीं चल रहा, पढ़ाई हो रही है. दिस इज नॉट अ सिंगिंग कंपटीशन, दिस इज अ स्टडी सेक्शन. हैज एवरीवन अंडरस्टूड? यस और नो? वैभव हैज अ क्वेश्चन. Yeah. Okay, देखो, PDA with a PS, no blood supply to the lungs through pulmonary artery. Warm blood has to go to the pulmonary trunk from the aorta. So PDA with a PS. So yes, my dear, see, simple, no. If there is just see, Dr. Vaibhav, if you have any doubt, first of all, everyone, my mobile number is 9999897081. Okay, this is my mobile number. Number one, we all have an amazing what you called WhatsApp and Telegram groups. You can come join, and of course you can ask me any doubt over there. So Dr. Vaibhav, you ask me doubt there on WhatsApp. Okay, like I'll easily tell you. Okay, let's move further. So I think it's already 55 minutes are over. So should we finish the class, or you want to continue further? If anyone feeling sleepy, we will finish the class here only. If you still have some energy left, then let me know. We will continue the class for 2 more minutes. Shall we continue? Manish, okay, yes. Dr. Grace says that it's raining here and by your singing you made my day. ठीक गाया मैंने. शुभम ठीक गाया ब्रो, खराब तो नहीं गाया? बता दे मेरे को यार, ठीक गाया कि नहीं गाया? Okay. Let's move further. 2 more minutes, quickly finish it off. Okay, so now could you please, now this is the next slot of questions. Okay, see, imagine case YY is going on. Okay, case YY is going on. So please tell me, name some duct dependent pulmonary flow lesions. Now I have tongue twisted the topic. Okay, duct dependent pulmonary flow lesions. What does this mean? Like I am asking, means in which condition pulmonary flow is largely dependent on the ductus arteriosus. Can anyone answer in the comment section, please? Yes, exactly. Anyone, please? It's a beautiful question. Are you getting it? Can you please name some congenital heart where the pulmonary flow is largely dependent on the ductus arteriosus? Means the pulmonary artery can't flow the blood there; it has to pass through the ductus. So, do we have any condition? Yes or no? Yes. The best answer. Can I say severe pulmonary stenosis? Such a basic answer. Can I say that? Yes or no? Severe pulmonary stenosis. Obviously, we have been talking about it. The patient has pulmonary stenosis. The blood from the pulmonary artery will not be able to go to the lungs, right? So obviously, I need a PDA. I need a PDA. Are you understanding, everyone? Hello. PDA. No, remember, see, bottom line. PDA, patent ductus arteriosus, we all know it is a left to right shunt. But naturally, if I keep the PDA open and I make a pulmonary stenosis, then PDA can never be a left to right shunt, because the blood which is coming from right atrium to right ventricle to the pulmonary artery, somewhere it has to go in life. So it will take the ductus arteriosus and then go to the descending aorta. Same like a fetal circulation. इस बात का गांठ मार लें. Please just clearly understand this point. Okay, let's move further. And also at the same time, tricuspid atresia with pulmonary atresia. Very importantly, tricuspid atresia. Do you remember, right, what I'm telling you? Tricuspid atresia. If this is a four-chambered heart, I'm saying tricuspid atresia. And also at the same time, I'm saying the pulmonary atresia. So pulmonary atresia and tricuspid atresia. In both conditions also, I need a ductus open. I need the ductus open so that the blood can move further. Yes, someone is very beautifully answered. TGA, everyone knows. I have taken a full-blown 1-hour class of TGA also, and of course someone is answering very beautifully. Infracardiac TAPVC and Epstein anomaly. See, now we are entering a very different level of studies. Okay, we are literally entering into a very beautiful world of pediatrics and pediatric cardiology per se. So it just, everyone knows that condition where the pulmonary flow is largely dependent on the ductus arteriosus. I have told you one very important part, TGA. TGA I have told very long back. I told that TGA is a duct dependent congenital heart disease. So the other causes are pulmonary stenosis, tricuspid atresia with pulmonary atresia, infracardiac TAPVC also, and Epstein anomaly. In all these conditions, I think opening a PDA will be helpful. Opening a PDA will be helpful. Are you understanding? I hope you get it. If you have any doubt, message me on WhatsApp. I'll try my best to figure it out. Okay. Next question. Yes, now please finish this little class. 55 minutes are over. Okay, I usually don't teach so long because I want you guys to learn to the point, a small happy class. Last question, then I'm going to finish the class. Name some duct dependent systemic blood flow condition. Systemic blood. Can anyone by mistake tell me what's the answer? One question was duct dependent pulmonary blood flow condition. Now I'm asking duct dependent systemic blood flow condition. I'm asking about the aorta. Anyone can answer in comment section. Quick answers. Weber tetralogy of Fallot can never be a systemic blood flow condition. Tetralogy of Fallot is a pulmonary blood flow condition. Are you understanding, doctor? Yeah, exactly. The answer, see, my question is name some condition where the blood cannot go to the aorta. Listen very carefully, please. I'm asking, name some condition where the blood cannot go through the aorta, and for that I need a open patent ductus arteriosus. Can I write aortic stenosis? Yes or no? Can I write that aortic stenosis? Obviously, sir, you can definitely write, sir. Aortic stenosis, no. If there is a aortic stenosis, blood will not be able to move to the aorta. It needs a bypass channel. In that case, by PDA sounds a better answer. Okay. That's it. Number one. Can I say a coarctation of aorta? Very important. Coarctation, such an important point. Coarctation of aorta. And in the further class we will talk about it. Like only simple I can tell you, this is the aorta. Okay, now here is the coarctation. There is a blockage here. I'll repeat again, this point, this looks like a coarctation. Okay, there is a blockage. This is known as coarctation. Blood will not be able to move from the upper limbs to the lower limbs, known as coarctation of aorta. So that's what. So then also I need a PDA, right? Yes or no? Do I need a PDA? In that case, you need a PDA for the blood should go somewhere. No, that's why you need a PDA. So the duct dependent systemic blood flow conditions are very importantly, we have very important. Acha, one more thing also, like the answers you got it: aortic stenosis, coarctation of aorta, and interrupted aortic arch. Interrupted aortic arch. Okay, yeah, that's what these three are the important causes. So now duct dependent congenital heart disease is a 5 marks MBBS question. Okay, and just writing TGA there will not be sufficient. Okay, so the answer will be the duct dependent congenital heart. Number one, we have the diseases from at the pulmonary level, then we have the diseases at the aortic level. Are you understanding? In both ways, I keeping a PDA open, I think it's quite helpful, right? Now one more question I have. Name some, last question, then this class is over. Exactly. Aortic stenosis and see, Dr. Osama, aortic stenosis is like a total block. Okay, coarctation of aorta is like a atresia, like a abnormal narrowing, and stenosis means totally almost block. The block will be in stenosis will be much more than in the atresia. Coarctation में थोड़ा almost block रहता है, stenosis तो पूरा ही खत्म हो जाता है. Name some duct dependent systemic blood flow. My question is, how will the patient present? Can anyone tell me which clinical feature? Which clinical feature? This is the last question of this class, then this class is over. Which is the clinical feature will the patient present of a coarctation of aorta or aortic stenosis or interrupted aortic arch? Can I have one specific feature that will definitely happen in the duct dependent systemic blood flow condition? Exactly. The best answer for this question is the patient will come in shock. Always remember, my dear, always remember, yes, exactly. Always remember that shock. Okay. So like whenever the major vessels are involved, whenever the aorta is involved, right? Aorta is a big thing. Okay. Aorta is a very big thing. Okay. So when some aortic component is compromised, the patient will come to shock. So this is very important. Okay. The aortic component, whenever it is compromised, the patient comes with shock. And the examples you have already told. We know severe aortic stenosis, we know coarctation of aorta, and we know interrupted aortic arch. Interrupted aortic arch. When aorta is involved, the patient will definitely come in shock. Okay. And I have a very beautiful question. Do you saw the transition? How more than the question? Tell me how's the transition? देखो उड़ के गया कोई. उड़ती चमन बढ़ती खिल्लू, वो गाना नहीं आता? हाँ, exactly. So yes. So now tell me, very important. Now the last question of this class is this only. When do these come with symptoms? If a patient of aortic stenosis or coarctation of aorta, I said he'll come in shock, right? The patient will come in shock. When the patient will come in shock? Can you please answer in the comment section? You have to literally open your brains for this. The options are day 1, the options are day 10, and the options are 15 to 21 days. What do you think? Last question. This class is happily over. Hanji, patient kab the symptoms, shock. I told you the patient will come in shock because aorta is involved and all that. When will the patient come with symptom, with shock? At day 1, at day 10, or 15 to 21 days? Very good. Mariam says A. Okay, great. Manish B. Priya C. आपस में बांट लिया सबने. Okay, then Arun A. Okay, someone says B. The best answer. Now remember the best answer. See, all these three components, tell me one thing, are they dependent on PDA? Yes or no? The answer is yes, of course. Aortic stenosis and all that, they are dependent on PDA, right? Naturally, just now we discussed, no, that just pick up one thing. Aortic stenosis, this condition is a duct dependent, right? It is dependent on the ductus arteriosus for the flow of the blood, right? That everyone knows about it, right? Yeah. So now my question, like the answer for this question naturally is when the ductus arteriosus closes, then the patient will come into shock. Are you understanding, my dear friends? And when do we have the functional and anatomical closure of ductus arteriosus? So you know that 10 to 15 hours, and the main closure is 15 to 21 days, right? Do you remember that? So that's what you have to think. Okay, when the PDA start closing, and the functional and anatomical closure happens in 15 to 21 days, right? And then the patient will come with shock to you, because if the patient has a aortic stenosis, for 15 to 21 days patient was kind of compensating because PDA was already open in aortic stenosis. The blood was nicely going from the left to the right, so baby was kind of managing. At 15 to 21 days, when the PDA automatically anatomically closes and someone is already having a aortic stenosis, gone, bang on, the patient will come to shock at 15 to 21 days of life. Remember that. Okay, that's it. Has everyone understood this much? This class is over now. This class is over. Thank you so much everyone for this wonderful participation. ये क्लास खत्म होती है. Thank you. Has everyone understood? Yes or yes. Okay, in the tomorrow's class, we have more amazing question to ask you. It's a very huge case presentation, and I want you guys to rock, to nail it as much as possible. I hope you had a great time. Thank you so much everyone for this wonderful participation. And before leaving, we always have a motivating quote, and today's motivating quote is that he has the most who is most content with the least. He has the most who is most content with the least. The moral of the story is, please don't expect anything from anyone. Okay, if you don't expect anything from anyone, you will be the best. You have nothing to lose. You will be awesome. You will never be sad. You will be chilled out, because you're not expecting, right? You're not expecting anything from anyone, right? You're chilled out, right? Chilled out. And that's what exactly. Yes, so that's what. Okay guys, remember, you have nothing to lose in life. Just be on your own, focus, tell yourself you are an amazing soul, tell yourself you are a peaceful soul, and tell yourself you have everything what is required to live a very crazy life. Okay, thank you so much everyone for this wonderful participation. Part 1 is finished. Tomorrow again 8:30 p.m. Monday to Friday, it's our deal. Every day 8:30 p.m. we're gonna come. Tomorrow 8:30 p.m. I have still more questions. This topic is not over. This case presentation is not over. I have literally more crazy questions to ask you. Tomorrow 8:30 p.m. please manage time to come, and thank you so much. And yes, love you too, Dr. Manish. And Dr. Khizra Khurshid says, nobody can get bored in your class. I am not NEET PG aspirant. I am a final year student from Pakistan. I just watch your lectures for better understanding of some concepts. Thank you so much everyone. Please take care. हाँ जी, मैं अमृत, अच्छा तूने मैसेज दोबारा मैसेज कर अमृत एक बार, मैं अभी देखता हूँ करके, अभी देखता हूँ मैं क्लास कब होगी. कल, tomorrow 8:30 p.m. guys. See you and take